All right, good morning, everyone. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Crystal Proud. Dr. Proud is the director of the Neuromuscular Clinic and the Spinal Muscular Atrophy Center at Children's Hospital of the King's Daughter in Norfolk, Virginia. She trained in pediatrics at Emory University. She then went on to train in neurology and child neurology at Stanford University. She remained there for her neuromuscular medicine fellowship and prior to returning to Virginia. During her subspecialty training at Stanford, she participated in landmark clinical trials, including one that supported FDA approval for the first treatment for spinal muscular atrophy. She's continued this interest at CHKD, where she now serves as primary investigator for several clinical trials, evaluating novel treatments for patients with various neuromuscular conditions. Please join me in welcoming Dr. Crystal Proud.
Good morning. Thank you so much for having me with you this morning. Today, we'll be talking about spinal muscular atrophy and the novel therapeutics that have been developed. So I do want to make you aware of my disclosures. So I participate in clinical research that is funded by 2 of the 3 companies that have FDA approval for medication treatment. I also serve as a speaker for Biogen and have in the past for Novartis, who make a couple of the products that we'll be talking about. And I serve currently as an investigator for Biogen, Scholar Rock, and Novartis Therapeutics as well. We'll be talking today about pathophysiology, the mechanism of action of various therapeutics, and my hopes and optimism for the future of our patients impacted by the diagnosis of spinal muscular atrophy. And we'll start with some cases because I feel like that's always a good way to start a talk. The first case that I'd like to share with you is of a 65-year-old man, and each of these cases I'll share with you are actual patients who I take care of now. Despite the fact that I am board certified as a child neurologist, my board certification in neuromuscular medicine allows me to have had training in both pediatric and adult patients that are impacted by neuromuscular diseases. And because what I do is so incredibly rare, we welcome all patients of all ages to my neuromuscular program here. So this was a 65-year-old man. He was a retired lawyer, and he stopped working about 5 years ago when he had difficulty walking. And he told me he was never an athletic child, but did get the ability to walk. He was walking slower in his 20s, had occasional falls throughout his 20s and 30s, and had more difficulty going upstairs in his 30s and 40s. So now he's in his 60s and he's able to stand, but he's using a manual wheelchair for mobility. Case number 2 is an 11-year-old young man who came to me because his mom noticed that he had been tripping and falling more recently. He enjoyed basketball, but was slower than his friends. He actually could jump, but not very high, and he was able to go up and down stairs. And his mom told me that he's walked differently than other kids, first noticed probably around 3 or 4 years old, and he was up intermittently on his toes. His mom also described a tremulousness that was in his hands and was not sure if this was significant or not, but wanted to mention it to me. And we'll talk more about that later. The third case is a 17-month-old little boy not able to pull to stand. When he was placed along furniture, he would try to take a couple of steps in a lateral direction to cruise, but could not accomplish getting into a quadruped position in order to crawl. He was able to sit independently and was seeming to have more difficulty recently with some loss of previously gained skills. And loss of previously gained skills, especially as a pediatrician and as a pediatric neurologist, is a huge red flag because you should never lose the ability of something that you have once gained. Case number 4 is probably a more typical case, which is a 2-month-old little girl who was seen at her well child check, and she was noticed to have differences in her breathing pattern. This actually prompted her primary care doctor to send her to the emergency room, which is where I met her. She had head lag, low muscle tone, And her parents told me at the time that her cry was softer than compared to when she was first born. She had no legs she had legs, but she would not kick into the air as a typical child would do. She kind of laid there, moving her arms somewhat, but also reduced vigorous movement there, but not kicking her legs into the air like we would expect for a 2-month-old. Her parents noticed that there was this trajectory, once again, of worsening weakness over the past several weeks. And so each of these cases actually illustrates spinal muscular atrophy. And so you can see the variety of different phenotypes and presentations that can happen with this one disease state. And so I thought we would start our discussion by talking about a disease state overview. The important thing to keep in mind is that SMA is actually one unifying genetic condition that's caused by a deletion or a mutation in the SMN1 gene, and it is diagnosed by a DNA molecular genetic test. Before we talk about the genetic testing, let's talk for a moment about the motor unit. So this is where my expertise falls within the peripheral neuromuscular system. And here is an illustration of what we call the motor unit. The motor unit begins at the anterior horn cell, which is sitting, remember, in the anterior portion of the spinal cord, where the motor neuron is sending out a projection via the nerve root and then the peripheral nerve, and making contact through a neuromuscular junction with muscle fibers. And that whole constellation of different structures is what makes up a motor unit and allows us to be able to move our muscles. SMN protein is essential to maintain the health of that motor neuron in particular. And when that motor neuron is not healthy, then it deteriorates. And when that motor neuron deteriorates and it no longer makes a strong connection with the muscle fibers, those muscle fibers will then atrophy over time. So SMA results from an SMN protein deficiency, and it's important for us to acknowledge where that SMN protein is produced. So the SMN1 and the SMN2 genes are two genes that produce the SMN protein, but they're a little bit different, and it's worth spending a couple of minutes here to talk about why they are different. The SMN1 gene in most healthy individuals produces sufficient functional SMN protein that allows for the health of that motor unit that we just talked about. The SMN2 gene, unfortunately, is an inefficient gene at producing protein, and this is because of exon 7 that you see characterized on our screen. When exon 7 is included during the transcription and translation process, this leads to a functional protein. Unfortunately, there's something called alternative splicing that happens with the SMN2 gene, whereby exon 7 is not included about 90% of the time. And when it's not included, that protein is not functional and it's broken down. And so without sufficient SMN protein, as in the case of patients with SMA who have a missing SMN1 gene and are only relying on this inefficient backup gene, their motor neurons deteriorate over time and muscles will weaken and atrophy. So you can see that our patients with SMA are relying only on this SMN2 gene, whereby each copy might produce a maximum of only 10% of protein. And this leads to that insufficiency. So the SMN2 gene produces mostly non-functional protein, as we've just mentioned. And this alternative splicing happens as a result of intron 7 that then suppresses exon 7 in transcription. And when that exon 7 is excluded, as we've just mentioned, the protein that is created is non-functional and it's broken down. SMA, unfortunately, historically has been a progressive neurodegenerative disease. And as we've mentioned, this is the result of a deterioration of muscular strength and function over the patient's lifetime. It's easy to think about muscles from an arm and leg perspective, but we have to think about where muscles are present throughout the body that might be impacted by a disease such as this. So we could anticipate that when we have muscular weakening, we're going to see progressive weakening of all of the limbs that might lead to progressive paralysis, the ultimate need for things like wheelchairs or other sorts of assistive technologies for mobility. We have to think, however, about how muscles allow us to do other activities, as simple as even breathing. Respiratory muscle weakness occurs because of the muscles of accessory respiration that are located on either side of the rib cage, as well as the largest muscle that impacts respiration, which is the diaphragm muscle sitting at the base of the lungs. And so my patients are impacted by having poor cough, impaired airway clearance, and then unfortunately, eventual respiratory failure. And this is typically what they pass away from. Bulbar function can be impacted as well, whereby patients have difficulty with chewing and swallowing. They may have changes in their voice, and they may have difficulties with managing saliva, because not only can they not swallow food or liquid, they can't swallow their own saliva sometimes. And they may experience musculoskeletal complications. These are patients that don't have increased tone, because tone, remember, comes from CNS disorders like cerebral palsy. But these patients can have joint contractures because of persistent muscle weakness. And when you aren't able to move your muscles throughout the range of a joint, you get stiffening of that joint, which is a contracture. In addition, when you have weakness in the paraspinous muscles that sit on either side of the spine, you're going to have differential movement that's going to lead to progressive scoliosis that might require intervention as well. What's important to remember in these patients is that their cognition is completely preserved. This is not a disease that impacts brain function. And so unfortunately, my patients are very well aware that they are stuck inside of a body that is not moving well. I will mention that each of the photos and some of the videos that I will share with you throughout this presentation have been approved for use and for sharing with you during this presentation by the lovely families that I serve. So let's talk about signs and symptoms of SMA. The family who's going to the pediatrician or to the neurologist might note that there is a failure to meet motor milestones. So when you go for that 4-month visit to the pediatrician, the family may say to the doctor, I'm noticing that she's not rolling over and she's not lifting her hands, and perhaps she's actually lost the ability to do some of these things over the past month or so. If you're seeing a 9-month-old, perhaps that 9-month-old is not yet sitting, or maybe the 9-month-old got to be in a position where she was almost sitting and then now can't do it anymore. And these are red flags and things that should make you think of spinal muscular atrophy. As I've mentioned before, loss of previously acquired skills is always a red flag in neurology and pediatrics, something that should prompt us to consider a deteriorating condition like SMA. And parents will often report a weak cry and difficulties with feeding and eating, not necessarily to the point where they're noticing their child is choking on, for example, in a young person like this, formula or breast milk, but it might take longer. It's taking 45 minutes to an hour for them to breastfeed. And this is because of involvement of some of those bulbar muscles that we talked about before. The neurologist or the primary care doctor may identify on examination that this is a child with low muscle tone and significant head lag. So when they're lying supine on a table and the pediatrician lifts them up by their arms, they have profound head lag, especially in the infantile phenotype. They're going to demonstrate leg more than arm weakness. There is this symmetric but differential weakness that we see. And that, I think, is actually readily visible in the photograph up here of one of my baby girls. And you can see that her arms are flexed. And so you know that she has some movement at the elbows here, but you can tell that only that right knee is flexed as she's lying there. And this actually speaks to the fact that she had minimal to no movement of her legs and more movement of her arms. And that's pretty typical of what we'll see in SMA. When we go to check the reflexes, we'll notice that there are low or absent reflexes in our patients with SMA. And they might actually demonstrate what the pediatrician noticed in that 2-month-old case that I presented, which is paradoxical respiratory movements. The child takes a breath in and the belly goes out. And this paradoxical respiratory movement is characteristic of SMA due to neuromuscular restrictive lung mechanics and differential weakness. This is more common than most people think, especially when we talk about the carrier frequency. So it's estimated that 1 in 38 to 1 in 70 people are carriers for SMA. And remember that the most common way that a baby can be impacted by SMA is by having a mom that's a carrier and a dad that is a carrier. And in that circumstance, that family has a 25% chance of having a child impacted by spinal muscular atrophy. It's inherited as an autosomal recessive condition. And it's estimated to occur in about 1 in 10,000 live births. Some updates to that number show that maybe it's more like 1 in 13,000. SMA is the leading genetic cause of infant death, unfortunately, because of the progressive and deteriorating nature of what we've talked about. And there are a variety of testing options that I'd like to touch on. So we can test patients who are symptomatic, and that's probably the number one time when we evaluate patients for consideration of a diagnosis of SMA. So I have a child that presents to me and they have hypotonia, they have weakness, they have low reflexes, and I'm sending off testing. However, these other tests can't be forgotten in the event that we have a family that is a family with known carriers. And I have a family that is in this circumstance now. Mom knew she was a carrier. Dad knew he was a carrier. This was tested by a family history of SMA that ran in the family. And so baby had an amniocentesis, and baby was diagnosed as having SMA before he was even born. This actually allowed us to follow this mom throughout her pregnancy, for us to prepare for treatment. And this child was actually treated at 9 days of life, which is pretty impressive. We have another mom who is pregnant right now, who we are following. And similarly, she knew she was a carrier. This is because she had lost a baby to SMA at 7 months of age, prompting testing of her and her spouse. And with this current pregnancy, they decided to pursue testing. And this current pregnancy is affected by SMA. So we're preparing for treatment, hopefully after the baby is born later this month. So identifying early diagnosis is important and can be done even before the baby is born. There's another circumstance of what's called pre-symptomatic testing, where there may be a family history of SMA and the family is not necessarily pursuing amniocentesis, but immediately after that child is born, before they have any symptoms, you may be looking at a baby who has normal arm and leg movements. Their reflexes may be intact. You're testing that baby because you know that there is still a chance that they may have SMA based on the family. Here is our testing algorithm, and this has been published in Neuromuscular Disorders. You can see the reference at the bottom of the slide. And this is a nice outline of what we're looking at when we're pursuing testing. So the testing, when you send this off, is going to result, in most cases, with an SMN1 and SMN2 as part of the report. And fortunately, these tests are available right now at no cost through 2 different laboratories via sponsored testing programs. And so I actually don't think twice about sending this testing. If you have low tone, if you have motor delay, even if I don't think you have SMA, I'm going to use this test because, man, would I feel horrible for missing something that I could potentially treat. So these days, my threshold for testing for SMA is very low. And I joke with my colleagues that everyone has SMA until proven otherwise. I think it's my bias. So on that test, we are looking for a deletion of SMN1. And if this test results showing that we have 2 copies, then this is not SMA. So even if you have a weak patient in front of you and they have 2 copies of SMN1, they don't have SMA. If this test comes back showing that they have only 1 copy of SMN1, then we have to make sure that that one copy that they have is actually functional. Because if we send this for sequencing and there's a sequencing abnormality, then that's a non-functional copy of the SMN gene, and they have a diagnosis of SMA. If they have one copy that is functioning, that does not have a sequencing abnormality, they don't have SMA. The most common case of a diagnosis of SMA is where we get 0 copies of the SMN1 gene, and that is a definitive diagnosis of SMA. The SMN2 copy number is also provided, and sometimes this can help to guide discussions about prognosis, but it's not a one-to-one correlation. So I can't say that because a baby has SMN2 copy number of 2, that they're going to have a definitive phenotype of type 1. We do think that the more number of SMN2 copies you have, the more potential SMN protein is produced. That makes sense, right? But it is not 100% of the time accurate. I have a patient who has 3 copies of the SMN2 gene. You would think that with that many copies, he might be stronger, but actually he had symptoms even at the time of delivery. He was profoundly impacted by SMA. There is a patient I have with 2 copies of SMN2, and because he has what's considered a low copy number, he would have been expected to have symptoms by 6 months of age, but he's actually that 11-year-old case that I gave you where we didn't diagnose him until he was a teenager because he was reasonably strong. So there are patients that break the rules. Here is what I'm referring to as types. So there are what I like to call historical phenotypes, and you will see if you ever read a note that I write that I actually don't characterize my patients as types 1, 2, and 3 anymore. And that's mostly due to an era of treatment where I don't really know what to call them anymore because they are defying their diagnosis. So remember that this is a unifying genetic etiology. Our patients with SMA have a deletion or mutation in the SMN1 gene and variable copies of that backup gene, the SMN2 gene. Historically, we used to group them as type 1, 2, and 3 based on these simple criteria here. Type 1 babies never reached the ability to sit. Type 2 babies reached the ability to sit, but never walked. And type 3 kids achieved the ability to walk even if they lost that ability. So that's how we characterized children and patients in general with SMA. And this really allowed us to do a couple of things. It allowed us to be able to place similar groups into clinical research trials because, of course, you want to compare and contrast groups that are similar. And it also allowed us to prognosticate, especially for that type 1 group. And we'll go over that a little bit more in detail. The picture in the bottom here on the left is a picture of a baby girl who has features characteristic of type 1 SMA. Without intervention, she would have been expected to never achieve the ability to sit. And because this is the more severe phenotype, these babies usually present within the first 6 months of life with weakness. Many of them display symptoms as early as 1.5 months, but there is this delay to diagnosis whereby they may not achieve a diagnosis formally until a couple of months later. You can see that she has some narrowing of her upper chest wall, which we call a bell-shaped chest, and she has a widening of her chest wall down towards her belly. She also has some excessive pronation whereby her arms are turning in. That's very classic for SMA. And you can see that she's moving her arms better than she's moving her legs, who ordinarily those legs would be up in the air and hers are lying quite still there. I cheated a little bit and I wanted to use a picture of one of my patients who stands and walks to demonstrate a type 3 phenotype for you. This is a young man after receiving treatment, though he actually is technically, if I were to type him, would be called a type 2. He did not achieve the ability to walk until after he had received treatment. But there he is, thrilled with himself, going shopping with his mom. In an era of new treatment, we have now characterized things a little differently, and we're still getting our footing about our language, but many of us will refer to these patients as non-sitters, sitters, and walkers. So a historical prognosis. Without intervention, we know that progressive loss of function is inevitable. And patients with SMA would require assistance with or be dependent completely for activities of daily living, including things like bathing, feeding, dressing, toileting, and grooming. And they may require various types of interventions, like the things you see listed here. If they have weakness and are unable to walk or have slowness with walking, they might require intervention with a wheelchair. If they have difficulties breathing and adequately ventilating themselves, they might require non-invasive ventilation like BiPAP or even invasive ventilation like tracheostomies, although we try to avoid that currently. If they have bulbar weakness and they have difficulties with feeding, they might require a G-tube placement. And then if they survive long enough and are strong enough to be in an upright posture, but have that posture not be perfect, we're going to see some more of that curvature of their spine and the need for scoliosis surgery with either rods or a complete fusion. This is the historical prognosis of type 1 patients. So those patients who usually present within the first several months of life. And this is work that was done by the NeuroNext group. And we see that the median survival is actually 8 months, and that nearly all patients with SMA phenotype type 1 pass away by the age of 2 years old. And so if I had a baby before the era of treatment that had 2 copies of SMN2 presented within the first several months of life and did not achieve the ability to sit, that baby was inevitably going to pass away by 2 years old, and I would have to have that discussion with the family at the time. This was really just 4 years ago, and it was a horrible discussion to have, that I knew that that there might be treatment eventually, but that I had nothing to offer at the moment except for comfort care. This is another demonstration of that very same fact done by work from the PNCR group, looking at survival that has a steady decline, more so in the 2-copy kids versus the 3-copy, but still a steady decline nonetheless in kids with SMA. And then looking at what's called the CHOP-INTEND score, and we'll come back to this later. This is a score that looks at motor function in kids under 2 years old that have SMA. And our patients essentially never go beyond a score of 40 without intervention. The maximum score on this test is a 64, and you can see that steady decline over time. However, the prognosis is changing amidst a new treatment landscape, and we have incredible hope now. And what used to be a very tearful discussion on both my part and the parents' part of sharing a diagnosis of spinal muscular atrophy, I now walk in with confidence and hope and optimism that we have treatment opportunities. Multidisciplinary care is part of that treatment opportunity, and this is part of the guidelines that are published by the Cure SMA organization and in the journal Neuromuscular Disorders, whereby the patient and the family are in the center of this care circle. There's a coordinator that can help to facilitate the care for these patients, and they may need a variety of different members of the medical team to provide care to them, typically directed by a neurologist or neuromuscular neurologist, and with collaboration from folks like pulmonologists, orthopedists, PTs, OTs, RTs. And actually, this is just slightly out of date as our care guidelines are being updated currently to reflect some of the newer members of the group that might need to participate in care of our patients with SMA. There are now 3 FDA approved treatments that are listed here, and we'll go over each of them. Nusinersen was the first FDA approved medication, and during my introduction, it mentioned that I participated in clinical trials during my fellowship, and we actually utilized nusinersen and administered it to the first patient in the world, which was pretty incredible and exciting. Although we didn't realize it at the time, we didn't realize how well these kids would do and that it would lead to an FDA approval. Actually, the FDA stopped the trial at 6 months because of how well the interim data was looking, and all of the patients were transitioned over to active drug because this was a placebo-controlled trial. This was FDA approved on December 23rd of 2016, a day I will never forget, after now 6+ years of clinical trial data and the largest clinical trial program to date in patients with SMA. It is indicated for the treatment of pediatric and adult patients with SMA, and it's administered through an intrathecal infusion into the cerebrospinal fluid of 12 milligrams 3 times per year after an initial loading dose phase. This is a picture of me that our local newspaper obtained. It does not usually look this technical when I'm doing these. It's a pretty simple lumbar puncture with an intrathecal infusion, but this is actually more complex because we're dealing with complex spines in some of these patients. And so my interventional radiologist has actually had to gain access for me to be able to push the medication into the spinal fluid. So this is how nusinersen works. It gets administered into the cerebrospinal fluid. It is endocytosed and enters the nucleus. It binds to SMN pre-mRNA, blocks that suppressor element in intron 7 that we talked about, and ultimately leads to more inclusion of exon 7. And this is exactly why it is FDA approved no matter your type, your phenotype of SMA, because all patients with SMA have an SMN2 gene upon which this medication can work. And it shifts that curve to create more functional protein. So this is a visual of what that looks like. It's blocking that intron 7 and allowing for more inclusion of exon 7 in the transcription and translational process, leading to more functional protein. It's administered through a lumbar puncture. And I like to show this graphic to parents who are a little bit nervous and remind them that I'm going below the level of where the spinal cord is stopping. I'm going in an area where we have spinal fluid and some nerve roots that are floating around. Now, in some challenging spines, which I have many, we sometimes have to use interventional radiology, and they may go a little higher. They may go into the thoracic space. And I actually do have some patients who require cervical infusions between C1 and C2. And I don't access them, I dose them. But my interventional radiologist, who is an expert in gaining access in C1, C2 through fluoroscopic guidance, provides access there as well. So this was called the ENDEAR clinical trial. It was a placebo-controlled trial that allowed for the FDA approval of this medication, whereby patients were randomized 2-to-1 to receive either nusinersen or the sham injection. And this really characterized treatment of symptomatic type 1 babies. Up front, whenever you're doing a clinical trial, you have to determine your outcome measures. And so in this particular clinical trial, the company said, we are going to consider you a responder if you meet these strict criteria based on a motor function scale called the Heine Section 2. And so you see listed here the criteria in order to be called a responder. This is the Heine Section 2. And each of these columns is awarded a number of points. And so you circle the point that corresponds to the child that's in front of you. So looking at head control, if they wobble, they get 1 point. If they have no head control, they get 0 points, and so on and so forth. And ultimately, you're left with a total score. And this obviously is going to change depending on your age in a typical child. If you're 0 months old, if you're 2 months old, if you're 6 months old, then there are some reference points that are outlined there as well. The data was published in the New England Journal of Medicine, and at the interim analysis, 41% of patients who received nusinersen met criteria to be called a responder. And at the final analysis, 51% of patients met criteria to be called a responder. And as I mentioned, this led to early termination of the trial and ultimate FDA approval. With this treatment, the survival curves completely shifted. And so there was a 63% reduced risk of mortality in the nusinersen treatment group, which was just a profound difference compared to what we know of the natural history. And in fact, that first young lady, she's now a young lady, who we dosed at less than 6 months of age in that clinical trial is now 7.5 years old, and she was incredibly weak and unable to really significantly move any of her extremities when she was first dosed, and now is sitting, and I think she's bearing weight on her legs, actually. So supportive clinical trials were utilized to evaluate this medication in other populations as well. So in our stronger patients, our type 2 or type 3, what we call later onset patients. So CHERISH was a study that looked at ages 2 to 9, and CS2, CS12 was an open label study looking at 3 years of treatment in patients ages 2 to 15 with either type 2 or type 3. And they were evaluated with a variety of different scores that are appropriate for those age groups, including something called the Hammersmith Functional Motor Scale Expanded, the Upper Limb Module, and the 6-minute walk test. We can see here that in the patients with type 2 SMA, they had a significant improvement in their Hammersmith score over 15 months' time. And we see that in the type 3 patients who are at baseline a little stronger, they still demonstrated on average 1.8 point improvement in their Hammersmith score over 15 months. And this is compared to what we know of the natural history, which is that our patients should decline 1.7 points after 3 years. Looking at the upper limb module, which is another functional test looking at what it sounds like, the upper limbs. In type 2 patients, the upper limb module increased 4 points, and this is compared to a natural history where we would expect them to kind of stay the same, if not decline, over 12 months. And in the ambulatory type 3 patients, our strongest patients, they improved their 6-minute walk test distance by 92 meters on average. And we know that the natural history tells us that they should actually decline in that ability. In that particular study, 1 non-ambulatory child gained the ability to walk, and 2 children who previously had lost the ability to walk actually regained this ability. It's important to keep in mind safety information, and so you can see here that the most common adverse reactions in the infantile studies were lower respiratory tract infections and constipation. And the most common adverse reactions in the later onset studies, where we have children who can talk to us, show that they experience some fever, headache, vomiting, and back pain. There are some FDA guidelines indicating laboratories that need to be checked, and you can see those listed at the bottom here. They should be checked before treatment and then with each subsequent dosing. Nurture was an incredibly important clinical trial looking at actually treatment of pre-symptomatic babies. And this evaluated treatment of babies who had been identified perhaps because of family history, not quite newborn screening because that wasn't really in place yet, but those babies received treatment before they were noticed to have weakness or low reflexes. And as of March 2019, whereby the mean age of patients were 3, and I know I need some updated data here. They have a data cut that's probably upcoming that'll be presented at next week's MDA conference. 100% of these patients were alive and without the need for permanent ventilation. 100% were sitting independently. 88% were walking independently. 92% were walking with assistance. And they were continuing to show improvement without regression. And remember that many of these kids are kids who would have been expected to not even sit on their own, let alone survive to age 3. So pretty incredible data that supported the institution of newborn screening. And I'm very hopeful that later this year we will have newborn screening in Virginia. Let's talk next about the second FDA approved drug, which is onasemnogene abeparvovec. And yes, it does take some practice and being able to say that. This was a drug that was FDA approved on May 24th of 2019 after data from 44 patients in an open label clinical trial and was indicated for patients under 2 years of age. It is a one-time IV infusion and the dosing is based on weight. And this is something that you'll want to keep in mind because the mechanism of action of gene transfer therapy is something that we will see more and more. We've actually seen this construct being used for a variety of different neuromuscular conditions. In fact, I recently dosed several boys and will continue throughout the rest of this year to dose several boys with Duchenne muscular dystrophy with a different type of gene transfer therapy, but the concept is the same. So gene transfer therapy is where we've taken a viral vector, taken the DNA from that virus out of the vector, and placed a piece of DNA that we would like to administer to a patient inside of it. So it's inside of this shell. It gets administered intravenously, crosses through the blood-brain barrier, whereby that shell then opens, releases that single strand of DNA, that DNA is self-complementary. It zips up into what's called an episome and then continuously produces protein, in this case, SMN protein. It does not change the DNA of the patient. So if you still do an SMA test, which is looking at DNA, it's going to come back positive. I've had that asked by families. The first clinical trial with this medication looked at a select group of kids that were administered this particular treatment at Nationwide Children's. It was called the START clinical trial. And patients were divided into two groups, the low dose and the high dose cohort. And the high dose cohort is the dosing essentially that we use now. And so that's the group that we'll focus on. They also were looking at including the symptomatic 2-copy kids that would be reflective of type 1 SMA. And at conclusion of this clinical trial, 92% achieved head control, 75% achieved the ability to roll over and sit unassisted, and 100% of these patients were alive and free of permanent ventilation. And remember when I told you that that CHOP and 10 score that we do in SMA patients who are untreated never reach above a level of 40? Well, this treatment broke all the rules. Very quickly, they showed improvements in their ability to rise above 40, all but one of them, and then maintained that ability. And several of them actually achieved perfect scores on this testing. The patients who were in the START clinical trial are now achieving follow-up through the long-term follow-up study. They're going to be looking over 15 years. And as of March of 2019, all 10 patients are alive and without permanent ventilation, and no previously achieved milestone has been lost. So there's durability of this treatment. STRIVE was a supportive clinical trial. This was multi-center, not just Nationwide Children's. And once again, looking at symptomatic type 1 kids. At the conclusion of trial, 91 patients were alive, 59% achieved the ability to sit. So keep in mind, they're defying their diagnosis there. And they had improvements in CHOP and 10 scores. As early as 1 month after infusion, we saw an improvement of 6.9 points, which is pretty profound. And an average improvement after 14 months of 23.5 points. So just like nusinersen was evaluated in pre-symptomatic kids, onasemnogene abeparvovec was evaluated in pre-symptomatic kids in what's called the SPRINT clinical trial. And this is ongoing. Data is currently being collected. And they divided the kids also into 2-copy and 3-copy kids and are following them over time. So far, the 2-copy cohort has shown that all patients achieved a CHOP and 10 score of not just 40, but more than 50. 8 patients so far are sitting independently. 7 doing so within an appropriate age window, and 4 patients are walking. And remember, these 2-copy kids should never achieve the ability to sit, and now they're walking. A 3-copy cohort was evaluated, 4 patients standing alone without support, 3 patients walking. And so once again, really supports early initiation of treatment. So we consider this a neurologic emergency. If somebody in my area or beyond my area is concerned about a baby with SMA, I want them to call me, I want them to page me, and I will see that child as soon as they can get into a car and get to me. Same day, next day, however long it takes them to arrive. Because we know the earlier we intervene, the better the outcome. Most common adverse reactions with this particular intervention are typical of what we would see with any gene transfer therapy. Liver inflammation being the biggest risk. This liver inflammation has to be able to be treated and able to be treated with expertise. I've had several kids where I've had to actually intervene with extra doses of Solumedrol. There have been kids around the country that have had to be hospitalized. So definitely a very serious conversation to have with families. We do administer corticosteroids to try to reduce the risk of that liver inflammation, and laboratories have to be followed very closely. So the third and most recent FDA approval is Risdoplam, and this is a drug that was approved on August 7th of 2020, and it's indicated for a patient 2 months and older, and it is a once daily oral liquid. It is an SMN2 splicing modifier, although it's not an oral Spinraza like many people say. It's not an oral nusinersen. It is working in a very different way, but it does modify splicing, allowing for greater inclusion of exon 7, leading to more full-length protein. This FDA approval was supported by clinical trials, including the Firefish clinical trial looking at type 1 SMA patients. And you can see the primary endpoints listed here. And after 12 months of once daily oral treatment, 41% of patients could sit without support for more than 5 seconds, and 90% were alive without permanent ventilation. After 23 months of treatment, 81% were alive without permanent ventilation. So significant results compared to the natural history. Firefish exploratory outcomes included 88% of patients able to eat by mouth and 88% able to swallow. And remember, that's that bulbar function that can be non-functional or dysfunctional in patients with SMA. This medication has been examined in later onset patients with type 2 or type 3 SMA by looking at a different scoring system that's more common in Europe called the MFM32. And in this clinical trial, patients were randomized 2-to-1 to receive either Risdoplam or placebo. They were evaluated in these age groups that you see listed. And over 12 months of all the age groups combined, there was an improvement in 1.36 points on average of patients who received active drug compared to placebo. Secondary endpoints included a change of 3 points or more on the MFM32, and you can see that more Risdoplam treated patients than placebo treated patients showed that change. And then looking at change from baseline revised upper limb module at month 12, more Risdoplam treated patients improved on that scoring system as well. Important safety information, once again, is critical when we're discussing options with families. Fever, diarrhea, and rash, are near about 20%. And that's something that has to be taken into account when we're talking about patients who are in wheelchairs or who have limited mobility, whereby that might create some significant burden on caregivers, on them. And so we do talk about this risk up front. And there are some other risks that are in the prescribing information that you can refer to as well. There are ongoing Risdoplam clinical trials, one called Jewelfish, that's looking at patients who have been previously treated with other SMA therapies transitioning on to Risdoplam. Rainbowfish, once again, with this drug, they're looking at treating pre-symptomatic children. In onasemnogene abiparvovec, there are ongoing clinical trials, including the STRONG clinical trial, looking at intrathecal administration. So remember that the FDA approved administration is intravenous. But in this ongoing clinical trial, they're looking at intrathecal administration of this gene transfer therapy in older and larger patients. This is on hold at the moment because of the FDA identifying animal data showing some inflammation of the dorsal root ganglia. I think that hold hopefully will be released in the next time period, maybe in the next year, I hope. But they do have to provide more data of safety before it can continue. Ongoing nusinersen clinical trials include DEVOTE clinical trial looking at different dosing timings and different dosing strengths, because right now we give the same strength of nusinersen no matter how old you are, no matter how big you are. And so this is looking at differences in dosing with nusinersen. And then the RESPOND clinical trial, and I am one of the lead investigators in this clinical trial. We are enrolling patients who have received onasemnogene abiparvovec, but still show symptomatic SMA, and we query, could they potentially benefit from additional nusinersen? And so we're going to be following these children over time to see if we add additional nusinersen, can we improve their outcome? There is a clinical trial that I'm an investigator for as well called the Topaz clinical trial using a investigational medication called SRK-015 in patients with type 2 or type 3 SMA. This is not looking at changing the molecular makeup of the patient. This is not looking at motor neuron stability. This is actually looking at muscle stability. So it's what's called an anti-myostatin, and myostatin is responsible for breaking down muscle. So the question is, can we use a motor neuron stabilizing agent and then add a muscle stabilizing agent and have them used collectively? And there was very positive result from the 6-month interim analysis across all 3 cohorts. Feet. So I'll conclude with the fact that SMA symptoms should prompt urgent and emergent evaluation, including genetic testing. Treatment is indicated without delay, given the evidence that we have of improved outcomes and reduced mortality. SMA is caused by one unifying DNA genetic change. And so the categorization of phenotypes is not dictated by genotype and is changing in an era of treatment. And prognosis and life expectancy are evolving, and one that brings us much hope and much optimism. Here are some additional resources that you can utilize in order to explore more. And I thank you for having me here today. I do see that there is a question in the chat box. I mentioned treatment of Duchenne with similar medication, and can I elaborate? I would be happy to, and actually perhaps sometime in the future I can come back and we can do another one of these on Duchenne. There has been much in the way of landscape improvement for Duchenne muscular dystrophy as well. And we have now started enrolling boys in gene transfer therapies. And actually that opportunity is exploding over the course of the next year. There are 2 companies right now that are about to have clinical trial enrollment that we'll be proceeding with here at our site. That's Sarepta and Pfizer, looking at gene transfer therapy. The 3rd company that does have a gene transfer therapy that I believe has completed enrollment and we are not participating in their clinical trial is Solid. So those are the 3 groups looking at gene transfer therapy, whereby we are delivering a dystrophin gene through this viral mechanism. And we have now dosed, we'll be on our 4th and 5th boys this month in that clinical trial. And so it'll be a little while before we have initial data from that. The age groups for this particular clinical trial are ages 4 to 7. Certainly, if you all have boys that you'd like to consider including in this opportunity, feel free to reach out to me. We definitely have had referrals from all over the US. We are one of 3 sites actually globally right now that is in this initial phase of clinical trial enrollment, and there won't be too many more throughout the country once they open up that clinical trial. So we're very fortunate to have that here in Virginia.
That's okay. All right, so for question 1, in the absence of treatment for spinal muscular atrophy, a patient's strength would be A, remain unchanged, B, progressively decline over their lifetime, C, improve continuously over time, or D, improve and then eventually plateau. If people could please respond to their answer in chat. Is that the correct answer, Dr. Proud?
So without treatment, we would expect for those motor neurons to deteriorate, and we would expect to see progressive weakening throughout the patient's lifetime. So that is correct.
And I'll ask question number 2. I'll probably need help with the names. Which treatment increases production of survival motor neuron protein by delivering a transgene of SMN1? It's A, nusinersen.
You got
B,
it.
the
Onasemnogene apaparvovec.
Thank you. C, Risdoplam, and D, valproic acid. If people could please respond in the chat.
While people are selecting their answer for what increases protein by delivering the SMN1 transgene, I'll make mention that valproic acid we did not talk about, but valproic acid was actually evaluated in clinical trial many years ago. And so many families actually requested that their child be treated with valproic acid in the past because of some potential benefit there, but it's not considered a treatment option that most of us would utilize now. So the correct answer to that question of which medication delivers a transgene to produce protein is onasemnogene apaparvovec. That's the gene transfer therapy. Part.
Yeah. All right, well,
Thank
like
you guys
that.
so much for having me. It's been a pleasure.
Yeah.